Welcome to the Healthy Habits for Active Aging podcast with your hosts, physical therapists Dr. Michael Gorman and Dr. Lauren Bennett. This podcast will discuss a variety of health-related topics focused on educating the aging adult, allowing for an active lifestyle no matter the age. Don't forget to rate, subscribe, and share. Enjoy the show.
Hello, and welcome back to another episode of the Healthy Habits for Active Aging podcast. I am your host, Dr. Lauren Bennett, and I'm a physical therapist out of the St. Louis, Missouri region. And today we gave Dr. Gorman a week off because we have a very special guest with us, and that is Dr. Wattles. And Dr. Wattles is an orthopedic surgeon out of St. Louis, Missouri, with the St. Louis Orthopedics and Sports Medicine group. So we just want to welcome you today.
Thank you very much. Thanks for having me, Lauren.
Of course. And today he's going to share with us a lot of information on specifically total knee and total hip replacements. So if you've been following our podcast the past several weeks, we've been talking a lot about osteoarthritis, specifically knees and hips. We've been talking about ways to manage that. So we've talked about cortisone injection, PRP, stem cell therapy, physical therapy, different conservative ways. But say you are finally decided with your surgeon, your doctor, or just decided enough is enough. Now you need to get a total joint replacement. So we are going to look very forward to hearing what Dr. Wattles has to say about that. We'll get to that in a minute. But go ahead and tell us a little bit about yourself, if you don't mind.
Yeah, well, sorry I interrupted earlier, but thank you very much for having me.
Mm-hmm.
I originally grew up in the St. Louis area, and now I am back after about a 14-year hiatus. I went off to college at the University of Kentucky, ended up staying there for both medical school and my orthopedic residency. That's ends up being 13 years there total. Out of residency, it's a really good training there. I decided to go into hip and knee replacement specializations. Orthopedists now that are coming out, over 95% now specialize in some sort of area of orthopedics, and kind of the generalist. You won't see probably many people go into that just basic general orthopedics too much anymore. So I ended up choosing hip and knee arthroplasty for a few reasons. First off, I really enjoy the patient population. It's the type of surgery where you have a lot of happy patients. The success rate for both hip and knees that are done well is 85 to 95%. And so when it's time to get one, people end up doing very well with these. And so that's a really rewarding experience in and of itself. And then also with my training, I specialize in kind of the big complex revisions of it. And I actually really like doing that as well, where you'll see a lot of people that just have these failed hips or knees that they just don't know what to do. And if you give them a chance to redo it, you can make a huge change in their lives. So after all my training, I was able to come back to St. Louis and work for St. Louis Orthopedics and Sports Medicine. Thankfully, I primarily specialize in the hip and knee replacements, as well as any sort of fracture work that might come in through the hospital. But I have really enjoyed it so far in the first 6 months that I've been with this group.
Great. And did you have anything in particular that sparked your interest in total hips and knees, or was it just the surgery in itself?
So I do like it's a little bit of the bigger surgery side of orthopedics. It's not necessarily, you're not dealing with small things. You do get to use the big hammers and saws for it, which is, I think, awesome. But it's really the construction aspect of it. You really are taking something that's broken and you're able to do this, very easily repeatable surgery and get a great outcome afterwards. And I really like being able to take something that isn't working right and be able to fix it to something that works very well. So that's what I really enjoy about it.
Yes. I remember observing a surgery at one point and looking at those tools that you guys use in the OR. It was like, these look like tools straight out of your shed. And then working on the other aspect of the rehab aspect with patients, they'll say like, why does it still hurt? And I'm like, you are 4 weeks post-op. What do you mean? Why does it still hurt? Do you see the tools that they use in there?
Oh yeah. Some people will tell me they would watch surgeries of what they're going to have done and they kind of regret it.
Yeah,
But
I say the same thing. I'm like, can you watch that after you have it done? Because I think you might talk yourself out of it. Um, but I don't know. Some doctors send, I don't know about yourself, but I've heard some doctors that send patients to like a class beforehand, not only like pre-op physical therapy, but like a pre-op class for expectations.
yeah, a total joints teaching class.
Okay.
And so that actually it's probably starting to phase out over the last 3 to 4 years, but I would say almost any joint surgeon 4 years plus, they would have programs like that at the hospital whatever they went to.
Okay.
And s- over those last 3 to 4 years, there's actually been a lot of studies that have come out that have kind of shown that no matter what kind of classes you'll send these patients to, you have all the same questions afterwards. They
Mm,
don't really change a lot of the anxiety level, and they don't do a whole lot for the outcomes as well. And it ends up just being kind of more of a burden for people that might have to travel in from out of town to
mm,
go to this class. And so now what a lot of people are switching to, like myself, is I've made a really, I would say succinct, but also a little bit long, maybe for some people, educational packet that I send out that specifies pre, peri, and post-operative timelines, instructions, what to expect. I have papers that when patient comes back for their 6-week appointment, they have it there to read in the office before they come back to see me for their appointment, just to say, hey, you're 6 weeks out. These are all the things that you should be expecting. And a lot of times that ends up answering a lot of the questions anyway before they even get to the office. And so it seems that a lot of this paperwork ends up being very helpful. And I've even gotten a lot of good feedback from what I've been giving patients as well.
yeah. And that is significantly helpful too on the physical therapy aspect of it, that, we're not, a couple days post-op telling people this stuff for the first time, that you want to get your swelling down, get your knee straight, and get your quad activating right away. So that's very helpful. Do you know if there's any research out there about like pre-op physical therapy, not just like the informational stuff, but actually going to PT before surgery?
That's a really good question. There is some information out there that does show that prehabilitation is helpful for post-op rehab. And so anytime I have a patient that is interested in it, I am more than
Mm-hmm.
happy to have someone do some prehabilitation. I actually wrote a prescription today for
Yep.
pre-op rehabilitation. I do think it's very helpful. There are studies out there that will tell you it's not, but it's really a fine line when you're looking at these things that are either statistically significant versus clinically significant. And so there are some papers as well as anecdotally that does show that the stronger you are with more range of motion you have before surgery, the faster you will recover afterwards and the better recovery you'll have. And so it's just not easy for a lot of people to do it. Usually by the time they see me, their arthritis is advanced enough that they really
Mm-hmm.
just can't always tolerate it that well. And so I tell my patients it's a fine line. I say, I would love for you to do it, but if all of a sudden you can't walk for some reason, if it's just hurting too bad, then we'll just hold off for after surgery.
Yeah, that makes total sense. So, what is your line? Say a patient comes to you and you get an x-ray, maybe they have moderate, severe knee or hip arthritis. Like, what indicates for you to tell this patient surgery is a good idea, or let's give it longer, go to PT, try some conservative treatment? Do you have like a gold standard?
I really don't. It's actually fascinating to me, and I still find it fascinating every day. I don't know how many thousands of hips or knees I've seen with arthritis, but everyone is different. I can see an x-ray before I see a patient, and it can be bone on bone throughout the whole knee and looks terrible. And when I go into the room and talk with the patient, they'll say it's a 2 or 3 out of 10. It doesn't
Mm,
bug them that much. It's really just this kind of stiff. And I'll just be like, well, if it doesn't bother you that much, I wouldn't do surgery because we could only make it worse. However, then I'll see someone who comes in, their x-ray beforehand is really just one part of the knee, has some moderate arthritis, not really bone on bone yet. And you go in and their knee is inflamed, it is
mm,
swollen. They've tried injections, the injections have worn off, the PT has helped, but they really just can't get over it. And there are two different knees there with two different types of x-rays of what you would expect to see. And there are a lot of studies right now that are going on to look at a patient's inflammatory like body type. They call it like an inflammatype, where some people's hips or knees with any little bit of arthritis will just become inflamed and irritated. It's almost like a rheumatologic type of condition where their bodies are just naturally prone to become inflamed, and those knees and hips hurt. And some people have the exact opposite of that. And they really, you could throw whatever you want at them and they don't swell, they don't hurt that bad. And so really when it comes down to when I see a patient, it's really more the exam and the history. If they are coming to me and they say, I just cannot do anything that I want to do anymore. I've tried, this, and this, and I just can't tolerate it. I say, well, it's time for surgery. And if they come in saying, well, I can do most of the things I want, I'm happy. I'm like, well, when you can't do the things that you want to do, then it's time for surgery. If you're having pain at night and can't sleep, if you want to golf and you can't even play around at 9, it's really time, because surgery is a very predictable thing to do with good outcomes that will get people back to doing the things they want to do. So an answer, no, I don't ever base it off of x-ray alone. The x-ray really only helps me for preoperative planning. So it's really based off of the patient and their exam and kind of what desires they have.
Right. Well, good. I'm glad you said all that, because our last episode topic was on knee arthritis, and it was all about how somebody could come in with like a horrible x-ray and not even know it. Because say that it was like dormant arthritis and it wasn't hurting. And then all of a sudden they gardened in the weekend and they knelt on it or something, or squatted, and then it flared up. So good. I'm glad.
So that actually right there, that is actually a really great point. And that's probably one of the most common conversations I have with my patients too, is really the presentation of arthritis. I'm not really sure if you've touched on that in the past before, but arthritis presents in many ways. And some of the most frustrated patients I get are some of these people that have it, and then all of a sudden something sets it off. Their body can tolerate it really well for a while. And then finally it says, I can't take it anymore. And the pain becomes just very different, and it's really just the arthritis. And then some people present where it's just kind of this gradual increase, like I have a little more aches, a little more pains. I've noticed over the last few years it's gotten worse and worse. And you'll have people that have this classic kind of peaks and valleys where I'll have a flare and it'll calm down, flare and calm down. And the most frustrated people are the ones that have what radiographically would be arthritis, bone on bone, with no symptoms, and all of a sudden anything, an extra weekend of hiking can set it off, and then their knee is just never the same again.
Sure.
And so you can always try to help them, and then it ends up that their knee is just, you can try you can try injections, but their knee is just said, I can't take it anymore.
Sure. And we've seen this too. Like I've had patients that are 60 years old. This happens. I've had patients that are 80, 90 years old. And so I commonly get asked the question, because I think it's kind of like old news that replacements last like 10 years, 15 years. And patients are like, well, I just want to prolong this as much as possible, so that way I can get something that lasts the rest of my life. And then I kind of have to say, well, go talk to your doctor about that, because these joint replacements are really lasting 20 plus years with what, the materials that they're using. And you don't want to wait too long, because when people do wait too long, they become weaker. They lose their stability of their joint even more. And the rehab process becomes a lot tougher. So do you have any thoughts on that?
Yeah, that's 100% true. And I'm glad that you're telling them that on the therapy side of things. So I'm coming out, I'm a little younger than a lot of, my counterparts. I'm coming out at a great time. The technology and the implants we have now are fantastic. It was maybe about 20 years ago that a lot of things started changing in the hip and knee arthroplasty world, both on the hip and knee side of things. It very much was the dogma that you need to ride out your arthritis as long as possible, so that you only have to have a surgery once that might last you 10 years, maybe 15. And really what it was the little plastic insert we would use to put in would wear out after that time. And about 15, 20 years ago, they made an amazing advancement in how they make that little plastic insert, that now they're seeing it last in 30 plus years. So now I pretty much tell anyone that comes in, unless they're 40 years old, because you hardly see a lot of, you'll see some, but I'll tell them your hip or knee is going to last forever. I just tell them that. I say, if I told you 30 years, I might as well tell you forever, because if it's in there 30 years, I bet you don't ever need anything different. And so now, because of all of this and the advancements in hips and knees, I don't even think twice if I see like a post-traumatic 30 or 40-year-old person's knee. that, something's happened, they've gone to arthritis. Like I don't think twice about saying, hey, let's do a knee replacement. It's your best option. You're going to get 30 plus years out of this. If we have to do something when you're 70 or 80, like it'll be okay. It'll probably be a smaller surgery than what we used to have to do. And so that's very much true. I tell them it'll last forever. And not even with that, but just the implants we're using in general now. Um, the inserts we're doing for knees, the types of knee replacements we're putting in are getting better and better at trying to mimic the native knee kinematics. And so your knee is a fairly more complex joint than a hip. Hip's a ball and socket joint, and people do great with hip replacements. There's been a lot of advancements in hip replacements and ingrowth into the implant so that you get a more stable implant sooner, so that it becomes part of you and will last forever, or even just for things like dislocations. And so that's been great for hips. But for knees are a little complex, where it's not just your natural hinge joint. There's a lot of anterior posterior motion, as well as kind of a pivot on one of them. And so a lot of the things that are coming out now for knee replacements are now really trying to mimic that native knee kinematics. And along with that, you can do things like a robotic assisted knee replacement, to where you're pretty much personalizing the knee replacement to every person, just through minor changes in your bony cuts. And all of a sudden, you no longer have to do these big sweeping soft tissue releases to now get your knee to balance and feel good at the end. So now that you don't have to do those, you're inserting this more supposed to be normal kinematic type of knee replacement. We're starting to see a lot of times that patients are having less swelling afterwards. Their recovery time is getting shorter. And when it's all said and done, their knee feels, it still feels mechanical, but it feels a lot less mechanical than what we were seeing in the implants we were using 20 years ago. So that was I kind of went a few different ways.
That was great. That was a great answer. I did want to back up as far as the longevity of the replacements, because I get asked this question a lot as a physical therapist. Well, do I have any restrictions? Say they're a really active person, they're a runner, they're an athlete, tennis player, golf, pickleball is the latest craze. I'm sure you're seeing a lot. I play a lot of that. So I have a lot of pickleball patients. Do you have any restrictions after? Are you one of those doctors that's like, nope, do what you want, live your life? Or what is your viewpoint on that?
So no, I don't. Cause I just educate the patient. I really don't. Like, the whole reason I'm doing a hip or knee replacement is I want the patient to do what they want to do. There are people out there that run marathons with total knees. They run marathons with total hips. There was, Andy Murray was a professional tennis player who ended up having a hip replacement in the middle of his professional career when he was like number one in the world. And then he got back to competitive professional tennis with it. And so I want people to do what they want to do. I just tell them it's always a risk benefit scenario, right? So if you want to go run marathons, you're at a much higher risk of, instead of that implant lasting 30 years, it may be 10 or 15 years. But when we say it lasting, it's not necessarily you have to redo the whole knee or hip again. It's more so the hope is that all that you have to do is really replace that one plastic insert that's more or less like changing a brake pad if it wears out, type of thing.
Okay.
These inserts or these brake pads we're putting in now could last 30 years. If you just go out and you drive around the country, making stops everywhere, you're going to wear it out more. But if that's what you want to do, you should do it. And that's my opinion. We can always take care of something down the road happens. We can always take care of it then.
Yeah, that makes total sense. I think that patients are kind of held back a lot by that fear after. And it's kind of disappointing, because most patients that need these replacements were fairly active individuals before, catchers in baseball, like that's kind of the reason that got them in this situation. And then to be told that they're going to have to just swim for the rest of their life they're like, what? So
hip and knee replacement's a pure like quality of life type of surgery. And it more or less it's an elective surgery, because if it came down to it, if you had to live with arthritis, you could. And so really the reason we're doing this is so that people have a happier lives. And why would you do something and then tell them they can't do something that makes them happy? I don't know. I don't really fall on that side of the spectrum. So I think that people should do what they want to do.
That makes complete sense. I agree.
The,
Okay,
the ca-
so
so I will say
go
the
ahead.
caveat to that is, I will, you do have to educate them, right? So when you're replacing something, for the most times, people may forget they have hip replacements. But if someone does go back to like a competitive sport, like a tennis or a basketball, you have to educate them saying, this is a knee replacement though, even though I don't have restrictions, you're able to do it. You may not feel like it's your normal knee. I mean, it is
Mhm.
still a mechanical knee. You're not going to hurt it at all, but it just may not exactly feel like you have just your 18-year-old knee, you need that you had when you're an 18-year-old. So, but still, there's nothing wrong with that as long as they just know that that's the case.
Okay. So I do know that you specialize in hip replacements as well. We've been talking a lot about knees, but you told me before that you particularly do the anterior approach. Can you explain exactly what that is and why you do that approach?
Yeah, that's a great question. So I did do my hip and knee fellowship. So I trained in multiple ways to do hip replacements. And what you're seeing is that a lot of people coming out of training now, as well as a lot of doctors are switching to the anterior approach. There's been a few studies over the last 5 years that showed, maybe 5 years ago, 20% of people were doing anterior hips. And then over this last couple of years, it's actually split to about 50% of surgeons are now doing anterior
Mm.
hips. And so there's a little bit of delay on some people fully switching to it because the learning curve is a little bit high for it. It's a little bit different than a lot of the older approaches. And so, some studies say it could take up to 100 patients to really kind of get it down. And not a lot of people want to do,
Mm.
surgery on 100 patients before they feel like they can do it the full way. So
Um,
um, doing everything. I like the anterior approach. One of the nice things about it, I think it really is truly a muscle sparing approach. You're not really cutting through or dissecting through any muscles. It's kind of one where you go through intermuscular plane. So pretty much where your incision is, you come right over a muscle and you kind of split them up. You just split them apart. And
okay.
you go right in between the muscles. You can do the hip replacement. And when you're done, you just let the muscles come back together,
Mm.
and you close it up. A lot of studies show that in the first 6 weeks, people are up and going faster. They're off of canes quicker. The recovery is quicker in the first 6 weeks. Now, with hip replacements, you're taking an awesome surgery that everyone does really well. It's like one of the top rated patient satisfaction surgeries behind like cataract or carpal tunnel.
Mm.
And you're just trying to make it a little bit better. And so for a lot of people do awesome at 3 months, this is just something that maybe in those first 6 weeks, people are back going a little, they're going back to the normal stuff a little faster. And with it, for me personally, I can use a specialized table that lets me take lifetime x-ray. It's very difficult to kind of take lifetime x-ray doing a few other approaches, but this one I can literally put in the hip replacement as I'm taking x-rays to make sure it's in the exact position I want it with no guesswork, so that by the time they leave the operating room, I know exactly what their hip's going to look like. I don't have to wait for a post-op x-ray to think, hopefully I got it right, type of thing. And then with it, there's a lot of good data that shows that the biggest thing for me that patients really like is you don't need to do any sort of post-operative hip precautions. The stability with anterior hips has really kind of been shown to be a little superior to posterior hips. And so with it, you don't have to do a pillow. And that's something I work a lot with the hospital therapists, the teaching of the patient. I say, I don't have any precautions with my anterior hips. You don't have to tell them to be, any particular way of tying their shoes. For the most, they've done a lot of really great studies looking at like tens of thousands of patients that they have had zero precautions on. And of a study where they had like 20,000 patients, I think maybe 4 had a dislocation.
Wow.
You're talking very minuscule numbers of people that have anything kind of like that happen with it. So that is one of the really great benefits of it as well, besides kind of people getting up and going faster, is that you really don't have to worry about any patient education when it comes to don't put your hip this way or that way scenario.
Yeah, no, that's really helpful because I think that on the patient aspect post-op, I get a lot of patients that are just like afraid to move. And then that really slows them down, So you're like, no, moving is good. Like early mobilization is key after these surgeries.
Yeah.
And yeah, so So speaking of early mobilization, how soon do you get your patients into therapy post-op, whether it's a hip or a knee?
So if I had my choice and if every patient
Mhm.
was agreeable with me, they would go to an outpatient therapy the very next day.
Mhm.
That's not feasible for a lot of, these older patients. And so a lot will have some sort of in-home, therapy, which is great, or
Mhm.
like home health come to their house. And it's day one, especially through COVID. The rates of same day discharges for hip and knees are extremely high. I would say in fellowship, I did over 80% of my hip and knee replacements went home the same day or seen the next day by a therapist. And then they see therapy a few times a week, per week after that.
Okay.
And so I want them going right away. The implants we use now, especially for hips, we put in with the idea that these people are going to be walking right away. We want them moving right away. And I don't have to worry about the hip like losing its place or anything like that because
Mhm.
it didn't hold its fit. And so, I plan for people to go right away. And that's what I really want. I think that and even shows with knee replacements, like the number one predictor of how well someone does early on is starting therapy right away.
Absolutely. No, I completely agree with that. When I get a fresh total knee, like I'm just like, this is awesome. They're going to do well. Even the ones that were eager and did a little bit of pre-op to have some expectations. Yeah, so many times I've gotten knees like 4 to 6 weeks post therapy and they're barely at 90 degrees. And we can get them there with a lot of manual therapy. But it takes way longer as well. And I don't know, this is kind of a totally different topic, but like pain medication, post-op, what is your view on that? Do you encourage your patients to take it, or if it doesn't settle well with them, what do you usually tell these type of patients?
Yeah, that's a great question.
Mhm.
And so coming out of training in the University of Kentucky, it's kind of like some parts of Missouri or West Virginia where it's a high um, opioid abuse area. And so out of that, state institution, there's these big overhauls with these multimodal pain regimens, both medicationally, but also you're talking about manually, so like icing and early range of motion. And I think that the amount of narcotics we have to prescribe now is a lot less than what we thought we needed to. I'm a big proponent to an anti-inflammatory for almost everyone after
Okay.
surgery that can tolerate it. Tylenol first line, kind of a cousin to a narcotic as a second line, and then a narcotic, third line for pain, fourth line. But really, it's the ice therapy, and for especially knees, just starting your range of motion right away is kind of the best way to start getting the swelling out and kind of help reducing that time period of kind of that more acute postoperative knee pain that you need medications for. And so I really think they're good to get them moving. So I usually just do it more so give them pain medicine so they can like do the therapy. That's the
Okay.
biggest thing. More
Yeah.
so than just getting them through stuff. But it's really for me, like I need you to take the medicine so that you can do your therapy.
Yeah.
And that's, when I have to prescribe stuff at like a 2 week or anything for refilling, it's really just like, hey, do you need it for therapy? Because that's really the
Yeah.
important time to use it.
So, if a patient is contemplating currently, when it's January of 2023, that they may need a replacement, do you encourage, like, is there any new technology soon to be coming out that doctors have their eye on, or what do you think about that?
Yeah, so I think the newest thing right now for knee replacements, even for hips, so the hip replacement, I think the new thing that came out is kind of people's transition is anterior hip.
Okay.
But for knee replacements, it's the robotic technology. A lot of the literature is really split on it right now on whether it's helpful or not. I will tell you a lot of it shows that your outliers for like a bad looking knee on x-ray are out the window with it. But also for me personally, where I've done hundreds of these and I've been practicing with some more senior partners of mine that have done thousands of these who all of a sudden like they said, I never thought I was going to go to the robotic knee, but I've seen how my patients are doing.
Mm.
They're coming back at 6 weeks looking like they're a 3 month post-op knee.
Wow.
And so I think for horizons, I think, the robotic knee replacement is really the thing that's at the highest forefront right now for knee replacements. That, along with kind of what I was describing earlier, where we are now trying to mimic the native knee kinematics with some of these new inserts and things that we have. And so for me personally, I use one of the newest type of inserts that we have that are really supposed to mimic your native knee, as well as using the robotic knee. That really kind of helps me cut down on soft tissue stripping. And I really think it helps the patients post-operatively with pain and faster recovery.
Great. Is there anything else you have for today? Any insight for any patients with future total joint replacements? Anything you want to leave advice for?
Yeah. So I think that when it's all said and done, hip and knee replacements are great surgery with high success rates. I think it really comes down to the patient. It's really the patient knows when they're ready for it. There are a lot of great things that you can do alternatively. Therapy can be very helpful. Injections, creams, there are new cutting edge technologies when it comes to procedural things with interventional pain doctors, where you're not doing a surgery, but maybe you're doing some sort of, nerve surgery, more or less a procedure. And so really it's just kind of finding the feel for where a patient is at in their life, if they're ready for a surgery or not. But, the success rates of hips and knees are very good. The complication rates in someone who's fellowship trained is less than 1%. And I don't know, I like them a lot. I think people do great.
I agree with that. And we've had a previous podcast on, the surgery. Sometimes once you give in to getting the surgery, that's almost the easy part, and understand that the work that you have to put into these surgeries after is the hard part.
My part is so easy. My part takes like an hour. I talk for like 30 minutes in clinic, and then I do a surgery for an hour, and like mine's easy. It's really the therapists and the patients that have the hard part when it comes to a lot of this.
Sure.
And so, and like the outcomes for knees, I mean, I could put in 6 different looking knees, but if you don't have a good therapist, and if you don't work at therapy afterwards, it doesn't matter what kind of knee you get, it's not going to feel right. But if you do the work and you have a good therapist afterwards, like, that will make the whole difference in the world when it comes to all of that.
All right. Well, you heard him. He said it. He backs us up for our previous podcast. But we really appreciate you joining us today, Dr. Wattles. You offered a lot of insight for anybody listening today. And hopefully, if this is yourself or a family member or friend that anybody could share this with, that would be very appreciative of us as well. So we thank you. And if anyone has any questions for Dr. Wattles, comments, or topics for future podcasts, as always, please email us at info@imovephysicaltherapy.com. And stay tuned. We'll be back next week on Wednesday, but we don't have a topic yet, so you're just going to have to stay tuned for that. We'll see you next week. Thank you.
We hope you've enjoyed this episode of the Healthy Habits for Active Aging podcast. If you have any questions for Dr. Gorman or Dr. Bennett, please send an email to info@imovephysicaltherapy.com. To learn more about healthy aging, visit our website at imovephysicaltherapy.com. Like what you hear? Be sure to rate and subscribe. See you next week.